Still good morning, everybody. Thanks a lot for having the nice opportunity to be here and in a place which became a real capital of metronomic therapies, as I have realized during the last 2 days. So let me share with you some of our ideas, how we are trying in a clinical praxis to cope with ever-evolving progress in science and with the uncertainty we have heard during the last 2 days. So this is just regards from the place I'm coming from. This is a Brno in the middle of Europe, Czech Republic. Actually, this is the place where Johann Gregor Mendel lived and worked, and the place where we held the first ever metronomic meeting. And the core people are still here, but just we lost some hair, gained some kgs, or we are more gray, but we are still believers. So let me integrate in my talk view of clinical pediatric oncologist as I mentioned, metronomic believer, and at the same time a regulatory person, because I am suffering as a member of pediatric committee of European Medicines Agency, which is European drug regulatory body, so thus I have nothing to disclose. Let me update you of our post-combat and pre-personalized interim series of metronomically and target treated patients with couple of index personalized cases and discussing some lessons learned over the last 2 years. Why still discussing the metronomics? Because our survival rate has plateaued, and probably since 2003-05, we have no real improvement in survival, and we have just increased our response rates, but not survival curves. And we are still using for our pediatric patients very toxic MTD-based chemotherapies on a first line, and with very unacceptable side effects, especially in terms of long-lasting side effects for children. What parents and children want now, they need to have safe and effective treatment available very early, not after 10, 12, 20 years, what is a usual time to bring new magic pills to the clinic. Why we are not improving? Probably because we are still using our old armamentarium, which is targeted to DNA, with just few examples which are targeting proteins as asparaginase or tubulin targeting agents, which are nicely described by our colleagues from Marseille. And we are still using traditional anti-cancer therapy-based killing paradigm, using the old prediction that the more we give, the better. But the model here assumes that we have a fixed time and space, and we have a non-mutagenic, no adaptation recruitment of protective cells, as we could see here many times. So what is our current situation while treating relapsed patients? So survival curves are miserable and didn't improve much during last decades. And one of reasons why is it that typically we are trying to learn from primary tumors and treat relapses, and we know that the overlap of genetic changes is just tiny one, as was published this year in Nature. So our post-combat pre-personalized series, which I would like to share with you, is composed of 43 children treated from January 2013, and 34 of them are relapse refractory who has failed on several lines of standard chemotherapy, high-dose chemotherapy, and plus-minus targeted. including 9 primary high-risk tumor treated with biological therapies, biology response modifiers at the primary diagnosis. And those are 1 malignant melanoma with bone and bone marrow metastasis, 3 sarcomas or rhabdoid tumors where we were able to find some putative target with bone marrow and bony mods, 1 nodal metastatic alveolar rhabdo, which was included into European Bernie protocol with avastin, 3 DIPGs and 1 gliomatosis. In 14 of them, the biological drug was chosen on based available tumor biology. This is just descriptive survival curves. What could support the use of metronomic chemotherapy or biologic is that for 28 patients who experienced second progression, the time to second progression is not shorter than a time to the first progression, which is not the usual situation in this setting. Male-female distribution didn't do any better or worse, and distribution of diagnosis is not showing any particular good or worse players which might be selected. This is a comparison of patients who got any of metronomic components: cyclo, VP16, celecoxib, fenofibrate, bevacizumab as a part of frontline therapies, and vinblastine. So those who got any kind of dose did a little bit better than those who were not given metronomic components of chemotherapy. Most of them, they are those frontline MTD-based chemotherapies. Patients who did not, let me see, kids who didn't any biological or those 12 children. Those are kids who get just metronomic treatment, and so they are doing quite well and not different from other group. And this is probably the most important slide, which is selecting patients who got targeted treatment based on some underlying biology, immune checkpoint blockers targeted treatment during the last 40 months, and those patients seems to have some survival advantage during the treatment period. And here this is just very few patients. So it seems the targeting agents based on mechanism of action seems to improve survival, but this is just pilot data. Toxicity profile, nothing really to be worried about very much. And further steps, as we discussed before, one size doesn't fit all. So let me show you a couple of personalized index cases. Relapsed Burkitt, we know that frontline Burkitts, they are doing extremely well, and survival rate is over 90% recently. However, for kids with relapsed refractory disease, there is almost no hope for survival, especially for those who are progressing during the reinduction. So for such cases, no hope. This is a kid who was diagnosed in December 2014 with a classical abdominal form of Burkitt lymphoma. He got BFM treatment, standard BFM treatment with one single shot of rituximab. Assessment after 2 cycles, very good response. However, 2 months later, there was an unexpected episode of intestinal obstruction with a nodular lipoid hyperplasia of a gut mucosa. PCR and histology was at that time negative for Burkitt lymphoma, which was positive at diagnosis. He completed in April planned protocolar treatment, so we were quite happy. However, during the June 2015, he developed abdominal relapse, CD20 positive, with a marked area of sclerosis, mesenteritis, as a mesenteric panniculitis. So at the time, the warning lights appear in our heads. So we have requested mutational analysis for PI3K delta kinase, and we started standard retrieval therapy with obinutuzumab, ibrutinib, and ICE. However, on treatment, we could see early progression. At that time, we got results confirming mutation in PI3K delta kinase. So we gave him idelalisib single agent window, and that's what we got. Germline mutation at a different level. There is a classical activated PI3K delta syndrome, one or two variants next to it. And so that's why we requested functional test, phosphoflow, which showed high activation in patients' T lymphocytes, especially on a S6 protein level. And this was not mirrored by MAP kinase and tyrosine kinase phosphorylation pattern. This is a phosphorylation pattern during the first progression in June 2015. You can see the S6 levels are very low, and when we did rebiopsy during the disease progression in September, we could see newly striking rise of p53 phosphorylation. So we have performed NGS panel, and tumor suppressor somatic gene alteration was confirmed here in line with phosphorylation pattern. We have done a whole transcriptome RNA-seq, which revealed next to standard what you would expect for a Burkitt, new information as an increased level for HR23B, which is a candidate cancer biomarker predicting sensitivity to HDAC inhibitors. And in line with that, from the rebiopsy from 2015. We could see strong PD-L1 expression in almost B or Burkitt lymphoma cells, and T cells, they were just on a periphery of the tumor, and few of them were CD8 positive. So what was our situation? In September? On a radiology, it was a stable disease after the 2 cycles of very intensive and highly experimental treatment. RICE plus ibrutinib and idelalisib, ibrutinib plus CIVE, which achieved disease stabilization. But the toxicity of MTD-based retrieval therapies was very severe. Lansky 8, tumor was strong CD20, strong PDN1 ligand expressing with HR23B. So question comes how to continue. Palliative treatment, because based on literature no hope to do anything, best supportive care, or to try experimental personalized treatment. After the discussion with the family, they agreed we are going to try something. So based on adult literature data, we went through ibrutinib, idelalisib combination, especially in light that ibrutinib is having very promising literature data on a patient immune system, shifting the balance between Th1 and Th2 in favor of Th1 response. And especially the preclinical data are supporting the combined use with immune checkpoint blockers. So this is a treatment what we give since that. low-dose cyclo, 50 mg per meter square, week on, week off, ibrutinib, idelalisib, nivolumab, Q2 weeks, and valproic. Doses of TKIs we used were just 40% of adult dose per meter square, and Zidelic was 50% of adult dose per meter square. We didn't experience any grade 2 or higher toxicity on this personalized treatment, and the boy is attending a school while reaching very good partial remission, which was confirmed by histology just last month. And the plan is to continue with the same. We have prepared dendritic cell vaccine from him because we have open dendritic cell trial. And open question is he candidate for allogeneic stem cell transplant as a germline mutation? So this case may illustrate a new variant of activated PI3K delta syndrome like Burkitt lymphoma. At present, Burkitt is not tested for and generally not recognized in children with Burkitt lymphoma, but definitely there are some hidden in our Burkitt lymphoma series. In patient history, there was no increased number or severity of infections or antibiotic use during the pre-lymphoma period, no adenopathy, no organomegaly. And what is interesting, the same germline mutation was proven in patients, a healthy father who is 45 years old. So, next, 2 cases of anaplastic ependymomas. We have heard something about ependymomas a few minutes before. 2 adolescent boys, residual unresectable posterior fossa ependymoma after several neurosurgical attempts with measurable R3 residuum, PET positive, both of them histology proven progressions after standard COG chemotherapy, radiotherapy trials. We went to see what's on a clinical trial gov. There is a open trial using everolimus in Texas, run by my friend Dan Bowers. So why not to consider mTOR inhibitors? We did again phosphorylation pattern of a patient, and we didn't see much activity in this pathway. So we have done whole transcriptome, limited DNA next generation panel, true site tumor, true site cancer at the time of progression. And the first patient we found on a transcriptome just increased expression of ALK, which is not reflected by FISH or immunohistochemistry, and cytogenetic RACGH, no aberration, so we took him probably subgroup A. And tumor microenvironment didn't show any strong positivity. Second patient, we didn't have available material for transcriptomic analysis, so just next generation show us the germline mutation in MSH6 gene and another germline one of helicase genes. And tumor microenvironment showed strong ligand positivity on almost all tumor cells. So we started experimental treatment since now 1 year. Azacitidine, valproic acid, as we know that especially the A subgroup of ependymomas are epigenetically based with low dose paclitaxel. First patient had a stable disease after 6 months and PET negativization at 1 year, just recently. Second patient, he had a stable disease after 6 months, so we added nivolumab at that point. Because of which is in line with this MSH6 mutation and based on strong PD-L1 expression, and at 1 year there is a markedly decreased PET avidity. Flat FLT PET is negative, and he's supposed to have a MR very good, and both they are outpatient based, no toxicity, and Karnofsky for both of them. So how does look the workflow? Surgery, biopsy, DNA, RNA extraction, transcriptome analysis, whole exome, whole genome sequencing, germline tumor, and combination with proteomic, phosphoproteomic data, and molecular oncology tumor board to start to propose something. Another case, infantile myofibromatosis with multiple visceral involvement and progression on 2 lines of standard chemotherapy. Again, based on literature, no hope for cure. This is a situation in August 2015. Terrible intracranial involvement with even leptomeningeal involvement of infantile myofibromatosis. We did phosphoproteomics, which nicely showing extremely high phosphorylation of PDGFR beta. So we have requested mutational analysis, which came out with germline mutation in PDGFR beta, and next to it heterozygous germline Nijmegen breakage syndrome mutation. So we started with sunitinib at very low metronomic vinblastine once a week since that, and this is a situation, this is a MRI response between August and January this year. One kid with DIPG. DIPG, we went for biopsy. Next generation TrueSight came with PI3K CA mutation, which is known for being as activated but resistant to EGFR inhibitors. And from phase 1 trial in adults, we know that this mutation is responsive to ACT inhibitors. The only one ACT inhibitors which was available to us was just miltefosine, Impavido, which has a label for treatment of adult patients with leishmaniasis. As the father was a physician and radiologist who actually did the diagnosis of his own son, we discussed with him the possibility to start we came with a proposal, so let's start with what is standard in our department for the IPG. It means nimotuzumab vinorelbine treatment and and radiation therapy, of course, and let's see the response. So this is the last April, after 6 months with nimotuzumab vinorelbine and radiation therapy. Nothing happened. So at that time we have added Impavido, this anti-leishmaniasis drug, and this is a response in January after several months. And just last week we have seen another regression of a tumor size and excellent general overall status of a boy. So whole transcriptome was done since beginning of 1915 for 26 children with different high-risk refractory tumors. 24 was investigated. In 2 of them we had suboptimal RNA quality, and druggable targets was suggested from RNA-seq in 24 investigated patients. TrueSight tumor, which is just a limited adult panel of 26 genes, was investigated in 86 children. 26 we found mutation in the tumor. In 4 of them more than 1 mutation, and in 3 patients germline mutations were found in just based on this limited panel. So shall we wait for new pediatric data? Pharma, as it was discussed even here, is still focused on adult condition, and it's very easy for our pharma to obtain a waiver for potential new life-saving treatment for children. And examples, at least in Europe, are crizotinib, ruxolitinib, cabizataxel. All of them were waived for pediatric development. And years are passing between initial adult trials and unless we can get the drug to our pediatric clinics. So it's always a matter of perspective. One is disease-centric. Most of our cooperative groups are disease-centric. Companies are drug-centric, as we could hear during those days. So drug-centric view, the design and conduct of studies are based on necessity for market authorization of a specific drug. Our disease-centric view is a design and conduct of studies of highest priority for children with a specific cancer. So what about a mechanism of action-centric? Different diagnoses sharing the same mutation or pathway, melanoma, low-grade gliomas. And what about patient-centric? Once we have different views, there is always potential for tensions. And where is the patient? Probably lost in translation. Pediatric oncology in Europe is organized in disease-based working groups. And what about mechanism of action approach? Where they do belong to? So, proper diagnostic biomarkers were widely discussed here. Question is, do we need panels or open-ended transcriptomics? Is it added something to genomics? Functional proteomics, liquid biopsies? I would like to turn your attention on this paper showing a theranostic profiling of pediatric high-risk osteosarcoma, stressing the human fingerprint hypothesis that probably we do not have the same tumors as we probably not harboring the same fingerprints. Our index case, what they are showing, it might be prudent in the cases where mutational activation is found to use some maintenance biological therapy, like in ALL, in a metronomic fashion. However, there is an important dosing question. As I stressed during the discussion, ibrutinib dosing was proposed by occupancy of Bruton tyrosine kinase. However, the dose needed to stop phosphorylation is 1 log lower than the dose needed to stop cell proliferation. What is a proper dose we need to offer our patients? And while we are not always able to eradicate the cancer or its causative mutation, we may be able to keep them well at school and active by prescribing combinations of low-dose metronomic chemotherapy, sometimes with immune checkpoint inhibitors or direct inhibitors of the activated pathways. The index cases. Is it too early for combined combo therapies? Please, let's wait for animal studies, more results. On the other hand, children with relapsed tumor, they do not have time on their side. And with full respect to all excellent preclinical studies we have seen, just have a look what was published this February in Nature about huge variability in animal preclinical studies, and really the mouse house may ruin studies. What could be evoked by single case? Probably it's time to revise our existing paradigms of developing drugs and approving them only if they meet their primary endpoint as monotherapies before they are tested as a combination. So what about our combos, cocktail of drugs? Why we are bent on demonstrating, and this idea I borrowed from our distinguished colleague here, we are still waiting to have a demonstrated efficacy of monotherapy before it's used in a combination. It's like building a car with only the frame and getting this approved before you edit all the engine, wheels and transaxle components. Ibrutinib in pediatric studies in the early phase, wait. However, there is a nice publication this year in New England Journal of Medicine showing that acalabrutinib, second generation drug, is showing much better response than ibrutinib. So, how far behind we want to stay with our pediatric patients? Wait, we do not have enough data. It depends. What does it mean and who says that? If it is regulatories, or healthcare payer perspective, we need to wait until we got enough data, or treating physician or the family perspective, because we would like to do something with John Brown, who is coming to my outpatient clinic today until he dies. What about randomized phase 3 trials? It was a nice discussion here during the symposium. Please, we have to keep in mind that the primary question, can we identify a person or small group of people for whom this is the right drug, is fundamentally different from asking which treatment performs best on a population level overall. And we try to summarize those ideas into recently accepted paper in Oncotarget together with Jan Clement and several other people. And what to say in conclusion? Phosphoproteomics is showing rapidly changing patterns of a tumor, similarly like antibiotic susceptibility. A relatively large an unexpected proportion of germline mutation or germline variants is found in our patients. Best clinical results, at least in our small series, we can see when DNA, RNA, and proteomic results are matching. And what are our ongoing projects? Combination, as you could see, whole genome, whole transcriptome, phosphoproteomic, and artificial intelligence programs to help us to identify the right targets and right drugs, and early incorporation of metronomic principle into newly diagnosed high-risk patients. Together with Nicola, we are fighting with our European colleagues to have a randomized question for a new generation of European protocol of metronomic maintenance after intensive previous chemotherapy in a chemo switch pattern. And second thing, unfortunately, Frank Berthold is not here, so just I would like to show you results of the METRO protocol, which is a metronomic protocol for relapsed neuroblastomas, and this is a old series, a German series, more than 300 intensively treated patients with relapsed high-risk neuroblastomas, and this is a pilot, 20 patients from Cologne, Brno, and 2 other centers treated with METRO protocol, showing that kind of results. So it pushed us together with Frank Berthold to propose a study for high-risk neuroblastomas, incorporating early component of metronomic chemotherapy into frontline high-risk neuroblastoma therapy after 4 intensive cycles before MIBG or transplant or both of them, and as a form of post-maintenance to continue with 9 more months. So whoever is interested, I would be happy to discuss potential participation in this early incorporation of metronomic protocol. And let me acknowledge the people who did the laboratory work for us, my clinical colleagues from my department, and my long-term metronomic friends, Nicolas André, Marc Hieran, Eddie Pasquier, Frank Berthold, Jan Clement. And
okay, thank you, Dr. Sterba.